Hello, welcome to your genitourinary elimination voiceover presentation. Today we'll explore the anatomy, functions, assessments, and nursing interventions related to urinary elimination. Let's begin. The urinary system is composed of key organs, including the kidneys, ureters, bladders, and urethra. Think back to your anatomy. Think back to your anatomy and physiology and how the genitourinary system works. The kidneys play a crucial role in sodium and water removal, waste elimination such as urea, creatinine, and potassium. Also hormone productions affecting blood pressure, red blood cell production, and calcium uptake. The kidneys are bean-shaped organs located on either side of the spine, just below the rib cage. Each kidney contains several vital structures that contribute to filtration and homeostasis in a lot of body processes. The renal cortex is the outer layer where initial filtration occurs in the nephrons. The renal medulla contains renal pyramids, which house loops of Henle and collecting ducts to concentrate urine. There's the renal pelvis. It's a funnel-like structure that collects urine before it passes into the ureters. The nephrons are the microscopic functional units of the kidneys, responsible for filtering blood and forming urine. Let's go back to the organs of the urinary system. Each organ in the urinary tract system has specific functions essential to maintaining homeostasis. Example, the kidneys filter blood, remove waste, and regulate electrolytes and produce hormones like erythropoietin, which have an effect on red blood cell production. The ureters transport urine from the kidneys to the bladder through peristaltic movements. Bladder stores urine until it's expelled, with stretch receptors signaling the need to void, and then the urethra channels urine from the bladder to outside of the body, controlled by internal and external sphincters. So urethra is the end. That's where that micturition occurs. Micturition is the process of emptying the bladder. Let's talk about urinary elimination. It involves several coordinated processes. The bladder typically fills with 150 to 250 mLs of urine before activating its stretch receptors. This triggers the voiding reflex center, leading to the detrusor muscle contraction and voluntary relaxation of the external urethral sphincter, and that is what causes us to urinate or to void. We talked about the functions of the kidneys, but what happens when there's dysfunctions? So biggest things for dysfunctions include fluid overload, meaning the kidneys are not working well enough to maintain a fluid balance in the body. So those with dysfunctions of the kidneys might suffer from fluid overload, which can lead to symptoms such as edema, fluid in the lungs, things like that. Elevated waste products. So if the kidneys are not functioning, then waste products are backing up. So increased urea, elevated creatinine, elevated potassium. There can be elevated magnesium, and then changes in hormone levels. So if the kidneys are not functioning, and we know kidneys have an effect on certain hormones in our body, such as the antidiuretic hormone or erythropoietin, then it will change blood pressures, it will change production of red cells, it can change the uptake of calcium, it can change the reabsorption of certain electrolytes that occur in the kidneys. A normal urine produces roughly 50 to 60 mLs of urine per hour, or a minimum of 30 mLs per hour. Depending on facilities you work at, they might just do the minimum 30 mLs an hour, or to be more specific, it should be 0.5 mLs per kilogram per hour. So this is based on someone's weight as opposed to a general minimum of 30 mLs an hour. Normal voiding should be 5 to 6 times per day. Frequency depends on the amount of urine being produced by the kidneys. In addition, it'll change based on different factors. This is just another diagram of how of the different organs in the GU system. Here's your bladder, a much closer look. You can see that it is a muscle organ. Full versus empty bladder. Here are your internal and external sphincters. Let me see if I can make this a little bit lower so you can see the whole picture. There you go. This one shows you the prostate, external sphincter, internal sphincter. Those are the muscles that either contract or relax. Okay, just again, another diagram of the bladder with the different muscles, sphincters, and this one actually shows you the pelvic floor muscles, which are right here. Here's the different anatomy, female versus male. All right. The process of urinary elimination, again, it'll fill 150 to 250 mLs. It activates the stretch receptor, signaling to the voiding reflex center, contractions of the trusor muscle, and then conscious relaxation of the external sphincter. And that's a big key point, is that it is conscious, right? We hold our pee until we're ready to go. Which has a lot of, which is what is affected when there are some types of incontinence. All right, so here are the factors affecting urinary elimination. So age, think newborns. They have no urinary control, and newborns won't have any urinary control until they're about age 5. So kids around age 5 are fully potty trained and have full control of their bladders. And then we have the physiological changes that come with normal aging that may affect urination in older adults. Some of the changes include the diminished ability of the kidneys to concentrate urine may result in nocturia or needing to wake up to go to the bathroom. Decreased bladder muscle tone may reduce the capacity of the bladder to hold urine, resulting in increased frequency of urination. Decreased bladder contractility may lead to urine retention and stasis, which increases the likelihood of UTI. This is why older adults are at high risk for getting urinary tract infections. Neuromuscular problems such as degenerative joint problems, alterations in thought process, weaknesses may interfere with voluntary control and the ability to reach the toilet quickly. So psychosocial variables, so think about anxiety and stress. Emotional stress can lead to urinary frequency or urgency or even retention due to muscle tension. Think about those nervous peers, like people who get really nervous that they have to go pee all the time. Depression may cause a decrease in fluid intake, reducing urinary output, increasing the risk of infections. Body image concerns. Think of those suffering from incontinence or having to use a catheter. Cognitive impairment disorders such as dementia can affect the ability to recognize the need to void and manage toileting. Past traumas. Individuals with history of sexual or medical trauma may experience anxiety related to urination and catheterization procedures. Social cultural aspects, right? Think privacy and modesty. Cultural beliefs about privacy may affect a person's comfort with urinating in public restrooms or even in a hospital setting. Gender roles. Some cultures have specific expectations for men and women regarding toileting habits and seeking medical help. Excuse me. Social norms include workplace environments, such as social settings may limit opportunities for regular bathroom breaks, affecting urinary habits. Think how nurses oftentimes have to hold their pee for a while before they can take a break because they're caring for their patients. That is a social norm. Religious practices. Some religions may involve restrictions on fluid intake, cleansing rituals that impact urination. And then language barriers. Difficulty communicating urinary symptoms due to language differences can affect delayed treatment. So environmental concerns, think locations of bathrooms, being able to go when needed, using different devices for urinary eliminations. For example, using a bedpan may not work for some, using public restrooms. Some people cannot physically use public restrooms. Food and fluid intake, well, when body functions optimally, the kidneys regulate fluid balance by ensuring fluid intake and output remain approximately equal. In cases of dehydration, the kidneys conserve water by reabsorbing more fluid, resulting in decreased urine output that is more concentrated. This is why when we can tell somebody is dehydrated by assessing their urine. Conversely, during fluid overload, the kidneys expel excess fluid by producing a larger amount of volume of diluted urine. Alcohol has a diuretic effect by suppressing the antidiuretic hormone, leading to increased urine output. Foods with high water content may also promote urine production, while those rich in sodium encourage sodium and water retention, reducing urine formation. Additionally, some foods can alter urine characteristics, such as asparagus and onions, affecting the odor, and then things like beets influencing its color. Medications have a huge effect on urinary elimination. Think of medications such as diuretics, which increase urine production, resulting in the need for increased urination and possibly urge incontinence. Sedatives or tranquilizers may diminish awareness of the need to void. Different medications can affect urinary elimination. And then lastly, pathological conditions. So if we think of pathological conditions that affect urinary, we're thinking of UTIs, incontinence, kidney stones, kidney disease. These all will have an impact on urinary retention. For example, a UTI may cause somebody to have an increased urgency. They may have burning when they pee. They might have pain somewhere along the urinary tract. So this is affecting urinary elimination. How do we promote normal elimination? One of the biggest things is providing privacy, a simple yet easily forgotten method to promote urinary elimination. Think of the people who can't really use public restrooms and things like that. They're going to have a hard time voiding in the hospital if they have a hard time doing it in public areas. Assist with positioning, right? Some positions are not optimal for voiding. For example, using a bedpan is not the easiest for some patients because there's no gravity helping bring down the urine. Think of a male patient who is using a urinal, but is having difficulty, and then once you stand them up, if you can, they're going to be able to void easily. Establishing toileting routines, huge way to promote normal elimination, especially for those who have some sort of incontinence, right? So having a schedule to ensure that they're not going to have accidents, and then in the hospital, if somebody is having incontinence, doing regular rounding of the patient to help them go to the bathroom prevents a lot of issues with elimination. Promoting adequate fluid and nutrition. Well, we know that proper fluid intake and proper nutrition affect elimination. And so we want to promote, eating vegetables with high fluid content, drinking fluids appropriately. And then the last thing is assist with hygiene. Hygiene is crucial for normal urinary elimination, right? If we're not wiping correctly, if we're not wiping at all, if there is improper hygiene, we can cause things such as urinary tract infections. And then let me go back to adequate fluid and nutrition. There are some foods and fluids that may increase the risk for kidney stones, which affect normal elimination. All right, so we're going to go into our urinary eliminations and issues with urinary eliminations and how do we help our patients. So first and foremost, we have to do focused GU assessments, right? We're going to assess mobility problems. Some diseases, some mobility issues will have an effect on urinary elimination. People who are not moving often tend to have urinary retention or even incontinence issues. Difficulty getting to the bathroom and removing clothing, that is going to have an effect on how they urinate. Difficulty performing ADLs. There are neurological conditions that we might need to assess that will affect the GU system, right? Multiple sclerosis, Alzheimer's disease, Parkinson's disease, difficulties communicating needs, difficulties performing ADLs, right? We want to assess all these things because we want to ensure that we're able to assist our patients and have optimal GU elimination. So subjective data we might collect includes past medical history, such as, do you suffer from chronic UTIs? Do you take medications, right? Have you ever had a medication that affects your urination patterns? Surgeries or other treatments, how often do you urinate? Do you have difficulty getting to the bathroom? We'll also assess the appearance of urine. This we might ask, maybe at that point in time they haven't provided a sample, so we wouldn't be able to assess the urine. So we ask, how would you describe your urine? Is there any odor with your urine? Any changes that you've noticed? Let's see. Do you say you go regularly? Do you drink enough water? Do you eat enough vegetables? Changes in urinary habits, so any changes in voiding patterns, right? Are you going more frequently? Are you going less frequent? Any changes in appearance or odor of the urine, and then again, history of any urination problems like UTIs, kidney or bladder problems. Have you ever had lost control of your urination? Any lifestyle changes? How much do you drink? Fluids. Do you drink water? Do you drink soda? Do you drink juices? So that is going to help assess their fluid intake patterns. Lifestyle includes smoking. Do you smoke? Were you a former smoker? Smoking is the leading cause of bladder cancer, so it's crucial to know this, especially because we know that that's going to affect genitourinary elimination. The assessment data for objective data you're going to collect is through your physical examination, right? In this picture, you can see a distended abdomen, and once you are palpating, you'd probably be able to feel the bladder. So doing a physical assessment is, of the abdomen, specifically in the pubic area of the abdomen, to see if there is any bladder distension, is there any pain, any discomfort, and then inspect for signs and symptoms of dehydration, urine appearance, right? If you can palpate, can you palpate the bladder? You shouldn't be able to palpate it, right? And then percussion, if you percuss, and there's tenderness, right? That would be an abnormal finding. So doing all these things. Other assessment data include using a bladder scanner to see how much urine is in the bladder, right? A bladder scanner is an ultrasound machine that measures the amount of urine in the bladder. How and what do we assess of urine? So big thing, we measure volume, right? Output. We inspect the color, the clarity. So is it clear? Normal is straw colored. Abnormal, it's typically amber. Cloudy. Note any odor, right? There shouldn't be an odor to urine. Sometimes it might have like a chemical odor, and that might be pretty normal, but it shouldn't be overpowering. We also assess by collecting specimens of urine, right? Testing it, sending it to the lab. Recognize what is an abnormal versus normal output. Again, we have that minimum 30 mLs per hour, or depending on the facility you work at, they might use the 0.5 mLs per kilogram per hour formula. And then, once we've assessed the urine, we're going to determine the factors that affect elimination. Is the voiding normal in appearance of urine? Going to assess past history. And then, is there presence of an ostomy or a catheter, right? Because ostomies do not necessarily mean it's going to be in the gastrointestinal system. We can have urinary ostomies, such as urostomies, nephrostomies, things like that. Yeah, so here you can see kind of some different assessment data you might see from voiding or urine collection. We're also assessing urinary patterns, such as are they having urgency or frequency. They're also assessing if they're having pain or sensations such as burning. Right? Fizzy, so normal excess protein, kidney problems. Clear could be excess water. Transparent yellow is normal. Pale straw yellow is normal. Honey or amber color means dehydration. Dark yellow could be normal but may need water soon. Brown is severely dehydrated and or liver disease. Orange is dehydrated. There might be liver or bile duct conditions or intake of food dye. Pink and red could have eaten beets or blueberries, rhubarb, or there is blood in the urine. Purple urine does not exist. Blue-green, there are some genetic conditions that might change it to that color. I've also seen medications that have turned urine blue or green. So that is the assessment of urine. So these are common urinary disorders or symptoms, because they're not actual disorders, but they are symptoms of certain disorders. For example, dysuria is painful urination. You would find this as a symptom in people with UTIs or kidney stones. Hematuria, so that's blood in urine. That might be a symptom for people who have kidney stones. They could have bleeding with UTIs. They can also have it due to kidney disease. Nocturia is urinating at night, having to get up to go to the bathroom at night. Certain medications might cause that, such as taking a diuretic. Polyuria is frequent or a lot of urination. This is a very common symptom for people with diabetes. Oliguria is low or not a lot of urine, so sparingly. This might be something that occurs with someone with kidney disease, end-stage kidney disease. And then anuria is production of no urine. So they are not making urine, so there isn't any urine production seen as a symptom of end-stage renal disease. Somebody that might be in dialysis, so they no longer make urine, so they need the procedure of dialysis to get rid of all the excess excretion of all the toxins and things that are built up in the kidneys. All right, we're moving on to urinary incontinence. So urinary incontinence alone is uncontrolled leakage of urine, sometimes due to lack of voluntary control over urination, health issues. They might need a lot of teaching, effects of quality of life. So think of self-image issues, right? If you're having accidents all the time as a grown adult, you might have some self-image issues, increased risk for UTIs, may give caregivers stress, right? If they're constantly having to clean them up. Skin impairments is huge for urinary incontinence. And then social isolation is another big thing, because adults who are having urinary incontinence might want to isolate because they feel embarrassed, right, about what's going on, if they're smelling or things like that. So these are things that we have to watch for urinary incontinence. So the types of incontinence include, let's see, so we have stress incontinence, which occurs because of weak pelvic floor muscles and or a deficient urethral sphincter, causing an involuntary loss of urine to an increase in intra-abdominal pressure. So what that means is that increased intra-abdominal pressure, such as like when you sneeze or cough, will cause urine to leak. Urge is the involuntary loss of urine that occurs soon after feeling an urgent need to void. Think of you really have to go, and you can't make it to the bathroom soon enough. And so you have a little bit of leakage. Overflow could be a cause of chronic retention of urine. It is the involuntary loss of urine associated with overdistension and overflow of the bladder. Mix includes a combination of stress and urgency and is marked by involuntary leakage associated with urgency as well as with exertion. Efforts like sneezing or coughing. Functional incontinence is urinary loss caused by the inability to reach the toilet because of environmental barriers, such as physical limitations, loss of memory, or disorientation. Also think of like when somebody is scared, right? Maybe somebody being held at gunpoint and they lose their bladder control from being over scared. That's functional incontinent, not necessarily caused by a physiological problem of the urinary tract system. Some nursing care we can provide would include preventing skin breakdown, right? So frequent cleaning, making sure that they're dry, encourage and teach lifestyle modifications, Kegel exercises, promote independent urination, anti-incontinent devices. There might be pharmacological interventions or medications that might be helpful in preventing incontinence, and then help with recovery from surgical interventions. So we're going to focus on urinary tract infections, which are infections caused anywhere along the urinary tract system. So it can start anywhere from the urethra, and it can travel all the way up to the kidneys. And so we're going to focus on urethritis and cystitis. All you have to know is that urethritis is inflammation and infection of the urethra, and then cystitis is infection, inflammation of the bladder. Pyelonephritis is inflammation, infection of the actual kidneys, and then urosepsis is a infection that starts in the urinary tract system and then gets into the blood system, and that's typically occurs as when the infection gets higher in the urinary tract. We are focusing on urethritis and cystitis and how we care for those patients. So nursing care includes lots of prevention. So ID patients that are at risk and assess for signs and symptoms of UTI. So what are the signs and symptoms of UTI? Typically, especially in older adults, is not a fever. And it might not even be urinary symptoms such as burning, itching, and pain when voiding. For older adults, one of the first symptoms is confusion. And so you have to know that an older adult who might all of a sudden be disoriented, they might want to be checked for UTI because it's not necessarily a fever or issues with voiding. Perineal care, so making sure we're doing appropriate and frequent perineal care. Increase fluid intake, and then assessing voiding habits, right? If we're holding our urine often and a lot, we might be causing ourselves a UTI. Educating our patients on prevention, educating them on how to care for themselves once they have a UTI, right? So that they need to take all their antibiotics, that they shouldn't stop taking it even though they're feeling better. Once we suspect an infection, we want to obtain a urine specimen. Always want to culture the specimen to grow and see what's growing. Most UTI infections are caused by E. coli, which are found in the gastrointestinal system. Always make sure that the patient takes their medication as prescribed, and then increasing fluid intake to flush any bacteria out. Urinary retention is another common condition that especially affects our older clients. So that's the inability to completely empty the bladder. One of the biggest causes is a large prostate, but also kidney stones can cause urinary retention. Management includes promoting normal voiding patterns, catheters as needed, avoiding caffeine or hot liquids, and then the triggers such as caffeine or coffee, sodas, things that will cause the bladder to spasm. Other condition that we were learning about is hypertrophy of the prostate, which, bear with me, I'm trying to remember, BPH, benign, now I can't remember the acronym. So BPH is benign prostatic hyperplasia, which is an enlargement of the prostate that puts pressure on the urethra, causing it to not be able to empty the bladder appropriately. This is a condition that can affect all males, and does not affect women because women don't have prostates. How do we care for somebody that has urinary retention or BPH? Of course, we do a focused GU assessment. We do what's called PVRs, or post-void residuals. This is where we assess the bladder with a bladder scanner after they urinate to see how much they're retaining. Most facilities will have protocols. For example, if we're doing PVRs, they might say if there is more than 300 mLs after voiding, do a straight cath. The patient might have pain. We'll definitely take some vital signs and measure intake and output. Sometimes care includes catheterization, so either intermittent or indwelling. And then when and if the patient can no longer void because of their obstruction, they might get what's called a suprapubic catheter, which is a catheter made with a little hole incision in the pubic area. And that is likely once that patient can no longer actually expel urine. Lots of education is needed. Sometimes toilet training can help, right? Having a schedule for voiding. But eventually, if the body can no longer expel urine, they're going to need some sort of intervention, such as intermittent catheterization, indwelling catheter, or suprapubic catheters. What is catheterization? So it is the introduction of a sterile tube into the bladder. There are 3 types: straight catheters, which are what we call in and out. They don't stay in. They're inserted and then empty the bladder completely and then taken out. While indwelling catheters, also known as Foley catheters, stay in the bladder for an undetermined time. And then suprapubic catheters are surgical catheters placed above the in the pubic area. Types of catheters are single lumen, meaning that there's only one port in there. Double lumen means that they can have 2 different ports, like they'll have like 3 tubes, and then, 2 tubes, and then triple lumen will have 3 tubes. So yes, those are different types, and they're used for different reasons. Nursing care when inserting a catheter. Well, we're going to verify orders, verify allergies, especially if facilities still carry latex style catheters. Gather supplies, explain the procedure, answer questions, provide privacy, always maintain sterile technique, and then refer to catheterization grading sheet, and then know your hospital policies. Nursing care for catheters. Well, catheters are at high risk for causing infection, so we always maintain it at a closed system. Keep bag below level of the bladder. Check for patency. Is it clogged? Flush versus change. Is it kinked? Encourage lots of fluids to help flush the urinary system. Avoid fluids such as caffeine, colas, teas, and alcohol. Provide hygiene, so perineal care. And then they might need medications to prevent bladder spasms. Documentation of the Foley. So once it's inserted, you want to take note of the size and amount of fluid in the balloon, patient tolerance to the procedure, and then initial output and description of urine. Was pericare done? Time and date, and any education provided. How do we remove a Foley? So once there's orders to remove it, gain consent from the patient, explain the procedure, check the records to see how much water was used to inflate the balloon that's holding it in place, gather equipment, provide privacy, know your hospital's policies. Some hospitals' policies require that you flush with 200 mLs of sterile water or fluid into the bladder and then immediately remove it. This is to promote urination after removal. Ask patient to relax, breathe in and out, and then ask them to exhale. And on that exhale is when you remove it. Then provide pericare. Document the removal and what is needed for documentation. All right, guys, that's the end of the video lecture. Please let me know if you have any questions. Thanks.